lecture series in radiation oncology. Доброго вечора, українці. So here's the slide for Stanford physicians. Stanford physicians can apply for CME credits. Please text this number to 844-560-1904. I will post this also in the chat. Today's lecture is on total body radiation and specifically Stanford VMAT TBI technique. Our first speaker is Dr. S'yuzi Hiniker. She's an associate professor and a pediatric radiation oncologist at Stanford. She specializes in treatment of pediatric tumors, total body radiation, craniospinal radiation, brain, CNS, and also rare benign diseases like Dupuytren and keloids. So a big hodgepodge. She is a real pleasure to work with. We all love S'yuzi, and we've been collaborating on multiple projects together, and specifically on introducing VMAT TBI to our Stanford clinic, also automated planning for VMAT TBI and VMAT CSI. So Dr. Hiniker will start with the clinical portion of the lecture. First portion, I'll finish up with the second portion. So we divided the presentation into two parts. So please take it away, S'yuzi. I'll stop sharing.
Okay, great. All right, thank you so much, Natalia. And yes, I'm very happy to speak with you guys today about the clinical aspects, particularly of TBI and the work that we've been doing with VMAT TBI, which is truly led by Natalia here. So just as an outline for the talk, we'll talk a bit about the rationale and the clinical indications for total body irradiation, as well as some conventional techniques, the Stanford VMAT TBI technique, and then Natalia will discuss also auto planning for VMAT TBI, comparisons between conventional and VMAT TBI, comparisons with other VMAT TBI techniques, the early outcomes that we've seen, and some conclusions. So to start with, when we're talking about total body irradiation, we're really generally talking about that in the setting of a stem cell transplantation. I won't go too deep into this, but as we know, stem cell transplantation is used in a variety of diseases. It comes in basically two forms. There's the allogeneic transplants, where a patient is receiving bone marrow or stem cells from a non-self donor, so from someone else. And this is most commonly used for leukemias and other hematologic malignancies. It also can be used in some cases, particularly at Stanford on the pediatric side, for non-malignant diseases. So children, or can be adults, but we see a lot of children with conditions like aplastic anemia, a variety of immune deficiencies, some hereditary, where they're getting an allogeneic transplant as treatment for that disorder. There's a variety of conditioning regimens that can get a patient ready for a transplant, and they involve really knocking down the bone marrow. Some of these include total body irradiation. Some of them are chemotherapy only. And the donor, as noted here, may be from a variety of sources. It can be a matched related donor, can be a matched unrelated donor from a registry, can be a haploidentical, that's happening more and more, which is a partially matched donor, which is sometimes a parent-child and sometimes a sibling. Sometimes it's an umbilical cord transplant from generally the stockpile. So it can come from many sources. Then separately, there are autologous transplants where the patient is receiving their own stem cells back to them. And those can be from, those are performed for some hematologic malignancies, such as lymphomas, myelomas, some pediatric tumors, such as neuroblastoma. And typically these, for auto transplants, these conditioning regimens are more often chemotherapy only, much less frequently do they use TBI. So which leukemia patients undergo transplant? Because not all leukemia patients need or are treated with a stem cell transplant. And we typically think about those. The most common leukemias that we see for transplants are AML and ALL. And thinking about the patients who you might be seeing for transplant include those AML in their first remission, so complete remission 1, with something intermediate to poor molecular cytogenetic prognostic features. or certainly patients who have refractory disease that does not respond well to their initial chemo, or patients who have already relapsed once, they're back in their second complete remission, and it's time for transplant. And sometimes those with just refractory disease, transplant might be used as a last-ditch effort. With acute lymphoblastic leukemia, so ALL, these patients can be transplanted in their first complete remission if they have high-risk disease for some reason, such as could be Philadelphia chromosome positive, could be other poor risk factors, or again, if they have a refractory disease. If not, if they relapse, they get back into their second complete remission, they're often transplanted at that point. And so why do we use total body irradiation, which really is radiation to the entire body, as it sounds like, as a treatment for these conditions or as preparation for transplant? This has been a long-standing tool used in the pre-transplant preparative regimen starting in the 1950s. And despite efforts to kind of reduce the amounts of radiation in many malignancies and treatment paradigms, it's still quite an integral part of the transplant regimen in many diseases. And it has a lot of benefits. So TBI's purpose is multifold. It's to eradicate the bone marrow of the patient so that the donor cells can come in and engraft. It has the benefit of eliminating any residual cancer cells. And so sometimes patients are going to transplant when they're MRD positive, minimal residual disease positive, and sometimes even when they're thought to be negative, they may still have some cells in there. It can eliminate cells that are still in sanctuary sites, such as CNS, testes, sometimes skin, where chemotherapy can't reach as well. And also has the benefit of reducing the risk of a severe graft versus host disease with immunomodulatory effects and reducing the risk of the host rejecting the donor cells. It's especially important in targeting the bone marrow throughout the body as well as the lymph system. And we do see, it's so important in that sense. We do see that now there are some protocols and regimens that are involving just treating the bone marrow and not treating, the rest of the soft tissue of the body. Those are still a little bit in the early phases, but certainly we do think about the bone marrow as well as the lymph as being really particularly the critical aspect that you need to treat. In terms of what we think for total body irradiation doses, when patients are getting a myeloablative regimen, and that really what that is really in the name. So myeloablative, it's really wiping out the bone marrow completely. Those are patients who are getting approximately 12 to 13 gray TBI, given 2 to 3 times per day. So it's over 3 to 4 days in these fractions, which are, I'd say, most commonly between 1.5 and 2 gray, although there can be a little variation there, but most commonly 12 gray and 6 fractions. And whenever they're getting the total body irradiation as a part of the transplant conditioning regimen, they're also getting a chemotherapy along with that. It can be cyclophosphamide, sometimes fludarabine, but they're getting an intense chemotherapy as well. This regimen, these types of regimens and transplants can be quite effective in terms of cure for leukemia. It's also a high risk and very intense procedure that's associated with a relatively high transplant-related mortality rate. So, 20 to 30% is a very reasonable estimate for what's the risk of somebody dying from the transplant process. And certainly that risk is higher in older patients, higher with certain comorbidities. It also, the myeloablative regimens are typically more effective in getting rid of the leukemia, but it's a trade-off of you also need the patient to be able to survive the transplant, or else you haven't really done them any favors. For those older patients, typically who do need a transplant, but would not really be candidates for the high-dose regimen, there are a variety of regimens that use a reduced intensity conditioning, typically 2 to 4 gray and 1 to 2 fractions. And those are also commonly the sort of TBI dose ranges that we're using in these protocols for the non-myeloablative transplants that we're doing in situations like aplastic anemia, immunodeficiencies, and those sort of non-malignant conditions. On the right here, you see from a survey of COG member institutions and what people are using for their dose and fractionations for TBI. And we see that the most common is 12 gray and 6 fractions, and that's actually really what the only regimen we use on the pediatric side here. It's given BID. On our adult side, it's a little bit more variable, where it's more dependent on the protocol the patient's being treated according to, which are often multi-center and can vary a little bit more. So sometimes it's 12 and 8, sometimes it's 13.2 and 8, sometimes it's 13.75 and 8. So many opportunities to get it a little bit wrong, so you have to be careful. But the ped side, fortunately, is quite standardized. And there have been studies kind of in that range of about 11.5 to 14 gray TBI. We see that with the higher doses of TBI, just like with the intensity of the transplant, there's better disease control but more toxicity. So it's a little bit of a trade-off. So do we need TBI included in these regimens? And how do outcomes compare between patients who are undergoing transplant and are receiving total body irradiation versus those who are receiving chemo alone regimens? In this trial, specifically called the Forum trial for pediatric ALL, was this really impressive, large, international randomized phase 3 trial that looked at randomized patients between ages 4 and 21 at the time of transplant, and they were diagnosed with leukemia between the ages of 0 and 18, so pretty purely pediatric population. And they were randomized to 12 gray TBI plus etoposide versus a chemo-only regimen that included fludarabine, thiotepa, and busulfan or treosulfan. This study accrued 413 patients who were randomly assigned to each group. And quite quickly, it met the stopping rule due to a significantly higher 2-year overall survival rate in the TBI group as compared to the chemo alone group. In the paper, they looked at this multiple ways and found this benefit existed in the intention to treat population as well as the as treated population, because there was a little bit of crossover, but really quite a striking difference. And they also found that the total body irradiation group had both a significantly lower rate of risk of relapse from the leukemia. That's what was mostly driving the difference, but they also even had a lower risk of a transplant-related mortality compared to the chemo groups. You look at the follow-up and you wonder still what is going to happen many years later. The authors noted that most leukemic relapses do occur after transplant within the first 24 months. So we've seen most of them that will happen. And also that really we don't see any more relapses after 2.5 years in the TBI arm, but it continued on in the chemotherapy alone arm, suggesting that the difference may widen. And that even if we do see, because this is overall survival, even if we do see some increase, some secondary malignancies in the TBI arm, this difference is so striking that it would be unlikely to change the survival advantage. So that's for pediatric ALL. So I think for pediatric ALL, we have extremely strong evidence that children should, at least between the ages of 4 and 21, should be treated with a TBI containing regimen if they're going to transplant. There's a lower population of adults with ALL. It's less common, but I think you can likely extrapolate this fairly well. And I would argue for it, TBI in an overall healthy young adult with ALL. With AML, which is the other kind of leukemia that we routinely are doing transplants in and myeloablative transplants, I'd say the data is less clear. We certainly don't have these very large randomized trials that are directly comparing outcomes. There are people, of course, interested in this question and doing meta-analyses of the trials that do exist. But I'd say it's a less stark difference for sure, and it's more debatable. Some institutions use TBI as a component of their AML conditioning regimens, and some don't. It's more, and they do chemo only. This is one example of the data that we do have. It was a long-term follow-up of 4 randomized studies of busulfan and Cy versus TBI and Cy in myeloid leukemias. And in the AML patients specifically, which is what these graphs show, there was a slight edge for TBI in AML. But this is only 172 patients, so an indication maybe TBI is helpful. But the CML patients, mostly adult, really, they had no difference in outcomes. So I think this AML is a little bit more debatable, and probably whether it's chemo alone or includes TBI is a reasonable choice. Okay, so TBI procedure techniques. is really an interesting thing. And I think what Natalia and I have learned in working with COG and on various studies about this is just that been struck by how differently different institutions do this. So as you can see from this picture and these diagrams, there are a variety of conventional treatment techniques that are all, reasonable that people use in different ways. They typically include an extended SSD with removal of the collimator. There's a translational beam approach, a sweeping beam. Sometimes the patients are standing, which is typically how we do it at Stanford with APPA format. Most commonly, the lungs are treated at a lower dose rate to reduce the toxicity. The dose rate is a little bit of a debatable point about how much that matters versus total dose to the lungs. And we know that the lung dose is reduced with blocking. Institutions do this differently too. So we'll get to a little bit of data later on, but essentially, some do like Stanford does and creates lung blocks for patients, each patient. And then under the lung blocks, also does a chest wall boost to try to make up that dose to the ribs that are blocked by the lung blocks. Some institutions don't do lung blocks. Some do laterals and consider the arms sort of the lung blocks. Some do lung blocks, for some of the fractions, but not all. It's just interesting how people do this quite differently. On this study, which was a COG analysis of trying to look at this issue of how are these different COG institutions blocking the lungs and performing their TBI techniques, and is there a correlation with outcomes? This study looked at 144 patients who were randomized to 2 different sort of systemic therapy approaches and all got TBI. And they looked at those patients who got lung doses. Well, we'll get to that part in a minute, but first I think to look at figure 2 is interesting, which is just basically showing that the blue lines are patients who received treatment TBI with APPA technique, and the purple is patients who received TBI with lateral technique. You can see that clearly those patients who are receiving lateral TBI are getting a lot higher lung dose. And then what this study did was look to see if there was a lung dose sort of cutoff where patients were having more or less toxicity or survival was affected by the lung dose. And they found that there was worse overall survival when there's a mean lung dose of greater than 8 gray. To go back to this previous slide, you see that probably with laterals, you are not really getting your mean lung dose under 8 gray almost ever. But that was a survival difference. And in that study as well, this may come up later, they also, it was interesting. They found that they couldn't find an increase in pulmonary toxicity with mean lung dose of greater than 8 gray, but the survival was worse. I think that to me mostly speaks to the difficulty of accurately counting toxicity, especially after a transplant, and correctly counting and attributing toxicity well. I think that it's often hard to tell where the toxicity is coming from. And so this might not always be attributed in the way it should. In terms of the procedure guidance for TBI, from TG29, the goal in the treatment planning is to deliver the whole body dose consistently and homogeneously plus or minus 10%. We know that with SSD thickness that there's a greater energy is better in terms of the dose homogeneity, but you have to consider the buildup region dose, and that we know that AP is better than lateral for this. Similarly, when energy and thickness are constant, having an increased SSD is more beneficial. We have a few questions. Natalia, are you going to do these questions? Oh, there they are. Okay, feel free to answer these of a typical dose for a myeloablative regimen. Okay, great. Great, perfect. Yeah, and I would say that is very correct. Good, 12 and 6. Okay, next question. Oh, yep, there we go. From the COG analysis, above what mean lung dose is associated with worsened overall survival? Answer that too. Good, that's right, really above 8 gray. Okay, next is from TG 29, dose heterogeneity for the patient, for TBI patient decreases with, I'll let you read the choices. Okay, and we can all select our answer. And it was a split. I did not answer this question. So yeah, that's lots of answers within this answer, but essentially the heterogeneity decreases with, we have to think of, you know, increases or decreases. So decreases with increasing energy, increasing SSD, and decreasing patient thickness. Yeah, perfect. Okay. And then finally, from this forum trial that we spoke about, which group has a significant overall survival benefit with TBI containing regimens, or at least what was shown in the study? And yeah, okay, good. It was, yeah, pediatric ALL, exactly. So I think that we can extrapolate from that to fairly well to young adult ALL. Pediatric AML, I think we don't have anything, or adult AML, we don't have anything strong enough to say that we know we need TBI, but you know, there's some indications could be helpful. So in just looking at conventional TBI techniques, Stanford is a center that treats a lot of patients with TBI, I think, relative to many others in terms of it being a component of our preparative regimens. And historically, and still today, we use many of these still. We have these 3 conventional techniques that are used. Most commonly, the whole body APPA standing at about a 6 or 5.7 millimeter SSD. Usually it's a BID treatment most commonly, and the AP will be treated in the morning and the PA treated in the afternoon. Generally, if the dose, prescription dose is above 8 gray, certainly we would do lung blocks. And if we do lung blocks, we also do a chest wall boost and keep the dose rate at less than 20. If really needed, although I've greatly moved away from this, and thankfully with Natalia's work, we have VMAT TBI in full strength here, so I don't do this anymore. If truly needed, you could do lateral seated with no lung blocks. I don't really like this for many reasons. It's, as we saw from the COG data, it's a higher lung dose. It's also worse. It's more heterogeneous, and you kind of don't know what dose you're actually getting. So I really like to stay away from this, but there was a time period where there were patients who we kind of needed to treat like this occasionally because they really couldn't stand. They were too big to kind of do this thing on the floor. And so this was our option. So we did it a few times, but it's not my favorite. And then the way that we treat very small children in the past under anesthesia was APPA on the floor with lung blocks. It's a little bit dicey for the anesthesiologist because, you know, there's the AP, okay, but then there's also the PA and they're getting flipped over while they're under anesthesia. So that was also, you know, something we did frequently when we needed to, but it's been much, much better with the VMAT technique. Typically 15 MV is used, and we create a patient-specific compensator and in order to keep the dose homogeneity within plus or minus 10%. The physicists and dosimetrists do really the lion's share of the work in this in terms of the calculations, and therapists with creation measurements for the compensator. We also do, when we use the standard technique, we use 50% transmission lung blocks daily for the APPA setup. And then because we're blocking approximately 50% of the dose from the lungs, we know that that is also being blocked from the ribs and chest wall behind the lung blocks. So we also measure what the chest wall thickness is and use electron boosts to boost the area under the lung blocks. And we use measurements as seen here of the chest wall. As written here, we also have something for a testes thickness. We don't routinely boost the testes currently, but if they did have involvement with leukemia at some point, then we will, and this is what we use for measurements. We know there's significant toxicity with TBI. Short term, these patients are very sick. It's not uncommon at all for standing patients to pass out in the booth. We have this little harness that they wear that doesn't fully support them for standing, but if they like pass out or faint, it will catch them, so they won't have a dangerous fall. But it's really quite common that the patients will, get dizzy, not being able to make it through a full treatment. They're ill and they've had a lot of chemotherapy. So very common that they have significant nausea from this, fatigue. Pneumonitis can be common, but it's also something that's a little bit tricky because it doesn't happen until well after the treatment is done. And so again, that sort of side effect attribution, it may not always be on the transplant team's mind that this is delayed from radiation. Parotitis, that can happen very early on, or submandibular gland swelling, and then dry mouth or mucositis. But really, I think by far the most common is the nausea and some fatigue. Of course, the late effects are common. Cataracts are common. That's one of the side effects where we feel like, at least if it happens, there's a effective treatment for it. But certainly for full dose TBI, gonadal failure is almost a certainty for these patients. And so we think it's important to counsel them about, sperm banking, egg preservation, if that's something that's important to them before the radiation. And then longer term potential dysfunction of other organs that are, less probable, but certainly still possible. But we know that the 2D technique is very hard. It's hard for patients who are standing, who are frail, or who have been through a lot of chemotherapy. It can also be really tricky to predict who's going to have trouble. I've had patients who seemed like they would be fine standing when I saw them in consult and simulation, and then 2 weeks later they come back for treatment and they've gotten maybe the chemo part of their conditioning regimen, and it was like a different person who was really not able to stand as well. We know that technically it's more difficult. The dosimetric uncertainty is much greater. We can't really accurately tell what any organ is getting with certainty. There's a need for creation of blocks. There's lots of very many, kind of manual input of measurements and numbers that can be error prone. Only certain vaults can do a 2D technique. And then we have that problem of these slightly older children who can't stand, and what do you do with them? And it's also hard on even the young children that you can use anesthesia on. The floor is not great. So the COG survey from a couple years ago shows everyone's sort of interest in this technique, in the technique of doing a more typically planned, 3D approach, and even more than that, sort of a VMAT potential approach to TBI. But it was at that time pretty rare that it was actually in use, and it's been increasing recently. The modern treatment planning and treatment techniques are somewhat similar and related, but different. There are a few places that are using helical tomotherapy for TBI. UCSF does a sagittal arc technique with static beams and patient on the floor. And then I'd say more popular, to my mind, is this multi-isocentered VMAT TBI technique, which is what we do, and several other centers listed here. We have written about our Stanford VMAT TBI experience, and it was first introduced, I guess, about 4 years ago now, and we've treated more than 100 patients, and probably quite a bit more than that at this point. And the physics team has done a great deal of work on creating automated planning scripts to make the planning easier and share them with the public. But as you can see from just these pictures here, these are very beautiful plans that you can really, finally you have a volumetric kind of data set to work with, and you can really both see what dose the organs are getting, and you can modulate it as you want to. I think we'll talk about the top right patient in a little more detail in a minute, but that was a little girl who had AML relapsed with skin involvement fairly diffusely. And so she was important to try to, increase the skin dose, which we could do with VMAT and boost a certain area of involvement, but still keep other organs and lungs to a minimum. And then you can see other pictures just of the areas we more typically spare for like a myeloablative regimen, meaning just lungs and kidneys. And there are fancy protocols now. People, I think one of our first ones was for the a scleroderma trial. So this is a nice video that Natalia included showing essentially how the simulation works. And the patients who are of a certain height get on the spinning Manny, which is what you just saw. And the patients are scanned both head first and feet first with the match line determined at SIM. They're in a whole body bag and with a knee fix, a foot fix, and arms tight to body. We don't use a mask for this, but they're pretty well immobilized. Here included are our typical dose limits that we use for this. So myeloablative regimens, typically we spare lungs, kidneys, and then sometimes lenses as well. Reduced intensity conditioning, I think this can be exciting for, especially for these non-malignant conditions like aplastic anemia. If we're treating to 2 or 4 gray, that we think of that as low dose in the radiation oncology world, which it is, but it's also, a lot of dose if the organs don't need it. So I don't think there's any evidence to suggest that the ovaries, testes, brain, et cetera, for aplastic anemia need radiation. And so if we can spare them from that 2 or 4 gray, we love that. And we include that. Those are as avoidance structures in those plans. Let's see, the PTV body is calculated as body -3, minus lungs +3, minus kidneys, and then any other OARs. And then a 5 millimeter flash is added during optimization to account basically for some margin. In terms of the VMAT beam placement, there's 3 VMAT ISO centers in the HFS and 1 to 2 in the FFS. And then the pelvis VMAT ISO and upper leg AP and PO ISOs are equidistant from the match line. There's an intentional overlap in the VMAT junctions such that there's not a absolute match line, which has the risk for being fully overdosed or fully underdosed. And it's typically 3 to 4 arcs per ISO. For the skin match, there's APPA, that's a skin match. And this is the optimization, which I will let Natalia talk about if she wants to come back to this later, because she is, a lot more knowledgeable about that than me. In terms of dose distribution, what we are typically getting is the D90 of 100%, and then accepting a D max really of up to, kind of get up to 115% commonly, or even 120 at times, but keeping it less than that. The 1 cc has been getting a 111%. And then typically what we see, or what we have seen for the lungs, the ovaries, kidneys, and brain are all in that range. The brain, for example, even if we're sparing it, it's still going to get some, reasonable dose, even if we would be fine with it getting 0, just because we do need to make sure that the skull is fully covered with no question about that, because that's a lot of marrow in that space. Okay, and then just finally for me, before I hand it over to Natalia, just a few exciting clinical uses for this technique that have been really great to use. One of the first patients, maybe the first patient treated with VMAT TBI, was on a scleroderma trial that required 8 gray and 4 fractions, sparing the lungs and kidney D mean to 2 gray, which seems basically impossible, and almost impossible even with VMAT, but I think it was able to be done. But certainly without VMAT, I don't think there's really a way one could do this and get acceptable coverage of the rest of the body. So this was one of the early plans of that. This is the patient I spoke about earlier, who they wanted 2 gray TBI as total body irradiation in addition to her extensive chemotherapy regimen. She also had this sort of widespread skin disease on the extremities, and then this one kind of larger buttock nodule lesion from disease. So this was just one plan, and you can do these really beautiful integrated boosts in a plan. It's really gives you a lot of freedom. The other great things about this are when you need to either spare an organ because of toxicity or some patient condition, or when you need to boost an organ or an area because of disease concerns in that area, you can do that. So we had this teenage boy who really needed a transplant for his ALL, but he also had terrible liver disease. He actually had been evaluated by the liver transplant team before going into stem cell transplant because they were worried his liver function was so poor that he might need a transplant, which he ultimately didn't for liver disease, but his stem cell attending was very concerned that this could, he could be at a huge risk for VOD or liver problems later on. And so for him, we felt that his leukemia was under actually quite good control, that his remission was deep in conversation with his oncologist and the stem cell transplant. And so we felt comfortable or reasonably comfortable, I guess, sparing the liver to try to avoid, worse toxicity in this. So I wouldn't always recommend, doing things like this, which are totally like one-offs and just because it sounds like a good idea. So I wouldn't routinely do this, but I think there are these special cases where you think that otherwise the patient really is not going to be able to get through transplant and they are in this very unique situation. So I think, this is a nice tool that if you really need to do something different, you have that ability. And actually this kid has done great, knock on wood, that was a couple of years ago. And so that's really good. And then just finally, I think this is the last one for me. Those cases where people have had prior radiation of a significant amount where you're worried that even your 12 gray of TBI could add toxicity. Often I think 12 gray is acceptable, adding it on to whatever was given previously. This girl had 60 gray to the brain for a strange like dural sarcoma a couple of years prior. And we felt that, just in case adding that additional 12 gray would put her over the edge for necrosis, and she didn't have any CNS involvement of her leukemia, we felt that we preferred to spare that brain as much as possible in terms of that really 60 gray isodose line. And so we spared that. But of course, making sure, priority was to cover the skull because that's an important area. Okay, I'm going to unshare. This is slide 37. I will let Natalia go on and talk more.